मैंने किया लेकिन वीडियो स्टार्ट नहीं हुआ है अभी यूट्यूब पे, मैंने देखा। ट्राई करता हूँ। All right, good evening friends, good evening all of you. So this is a so this is an evening just before Diwali. I know all of you are busy shopping in festivities, all of you are in festive mode, but first things first, exam is just around the corner. I know it is difficult for you to concentrate at least for maybe 2 3 days, but you have to do it. You have to grind yourself in a way so that you're across the finish line just on 9th November. I think that's the day for the exam, right? So let's start with the YouTube live session. We'll talk about the most important previous year questions for INI-CET November 2025 session. Okay? Good evening, all of you. Good evening, Aarti. Good evening, Shani. Good evening, Amano. Good evening, everyone. Good evening, everyone. So before starting with the questions, I just want you to know what are the most important chapters and topics out of which the maximum number of options, maximum number of questions are expected. So from growth and development, we have theories and application based MCQs, specifically the Scammers growth curve, the cephalic gradient of growth. From development of dentition and occlusion chapter, you have anthropoid spaces, early and late mesial shift, questions on leeway space of Nance, questions on questions on dental age, which can be identified from OPG, questions like that. Then from etiology and classification of malocclusion, you have IOTN. You have both the health components of IOTN, the dental health component, the aesthetic component, application based questions, numerical based questions, image based questions, and everything. Just give me a moment. Just give me a moment, please. हेलो जी, गुड इवनिंग। गुड इवनिंग, कौन बोल रहे हैं? मैम आपको थोड़ी देर में कॉल बैक करता हूँ, बिजी हूँ मैं, थोड़ा सा रुकिए, मैं आपको करता हूँ। हो गया स्टार्ट हो गया। Sorry about that. Sorry about that. Then from etiology and classification of occlusion, I told you premolar classification and Ackermann Prophet classifications. From cephalometrics, you can have certain application-based MCQs. You will be given certain uh, clinical situations. You'll be given certain cephalometric norms. You have to make a diagnosis and you have to make an associated treatment plan. Questions like that can be asked. Then from diagnosis and treatment planning, essential diagnostic aids, clinical based scenarios. We have talked about a number of clinical based questions earlier in different GTs. Okay. Then from biology of tooth movement, yet another important chapter. You can expect questions from pressure tension theory. You can expect questions from secondary messengers. I've included those questions in the forthcoming MCQs in this particular session for you. Then from biomechanics, we have moment to force ratio, counterbalancing moment based MCQs. Again, I have certain MCQs for you. Myofunctional appliances, principles, current theories, image based question, registration by it, concepts behind registration by it, uh, concept behind the mechanism of action, concept behind the tongue and its importance in myofunctional appliances, questions like that. Then again, materials used in orthodontics, yet another important question, important chapter, wrought alloy properties, especially corrosion principles. Questions like these can be asked on a very frequent basis. Then nickel titanium, superelasticity, shape memory effect, questions like that. The major surgical procedures, you can expect questions from BSSO, distraction osteogenesis. Nowadays, I have seen a trend about questions from envelope of discrepancy and cleft lip and palate. So you have to be aware of envelope of discrepancy. Then from interceptive orthodontics, questions on deep bite, open bite, cross bite, habits, space maintenance. Although space maintenance is a part of preventive orthodontics, still I have included that in interceptive orthodontics because you are actually doing some intervention. You are actually preventing the spaces from closing up. Then methods of gaining space. This is an important chapter. You will have n number of image-based questions specifically. I have seen many questions which are asked as image-based questions for molar distalization, arch expansion, for slenderization, proximal stripping. Okay, so these are the important chapters. Amano has asked how many questions are repeated from PYQs in MDS and INI-CET, sir. Okay, Amano, how many questions are repeated? That's a difficult question to answer basically. You know, you can think it this way, that the more number of questions which are repeated, it will be easier for every one of you to answer, right? If you get an answer right, so there are more chances that your competitors will also get the same answer right. The new questions are the ones which decide whether you are a rank holder or not. That's where the complete test of knowledge comes into picture. That's why I always keep saying that you have to grasp the subject in such a way that whatever new questions the examiner is asking, you should be able to answer them with full confidence. So it's a very difficult question. Exactly what's the number of PYQs which can be asked? It can vary. If it's an easy paper, you can have maybe 25-30% PYQs. If it's a relatively difficult paper, you can have maybe 10 to 15% PYQs. Rest could be new questions. Okay? All right. So question number 1, which I have selected as one of the most important PYQs. An 18 years old male patient with unilateral cleft lip and palate underwent surgery for cleft lip repair only. Now this is a $1 million question. It's a $1 million question. The patient is an 18 years old with unilateral cleft lip and palate who underwent surgery for cleft lip repair only. Please mark my words, cleft lip repair only at 6 months of age without palatal repair. So this is a fundamental clue hidden within the question. I'll tell you how. What occlusal finding is most likely? Normal posterior occlusion, posterior crossbite, anti-crossbite or anti-open bite. Now, the question is saying he underwent for cleft lip repair only without palatal repair. So, in all probability, once the palate has not been touched by the cleft surgeon, so there is no damage to nasal septal cartilage. There has been no damage to nasal septal cartilage. So the nasal septal cartilage, which is the primary pacemaker for the growth and development of the entire nasomaxillary complex, it is functioning to its fullest. It is functioning at its fullest. There has been no damage. There has been no scarring, nothing. So, when there is no damage, please listen to me very carefully. When there is no damage, the maxilla is going to grow properly in the transverse and anteroposterior dimension. Once the maxilla is able to grow properly in the transverse dimension, you will observe normal posterior occlusion. Excuse me. Some of you might argue, why not option B? It's because it's because if the patient had been operated upon for cleft palate repair की surgery अगर हुई होती, then in that case there would have been chances that the surgeon could have iatrogenically unintentionally damaged the nasal septal cartilage. In that case, the maxilla would not have been able to grow properly in the transverse dimension. In that case, you will observe posterior crossbite. But here in this question, there has been apparently no damage to the nasal septal cartilage, allowing the maxilla to grow properly in the transverse dimension. Hence, we will observe a normal posterior occlusion. Is it clear, guys? Please type yes or no in the chat box. I want you to understand this concept. It's a $1,000,000 question. I've seen students making silly mistakes in this particular question. That is why I'm stressing this again and again, that you have to read the language of the question properly. You have to assimilate the clues given in the language of the question properly. And then you have to go forward into attempting it. Please let me know in the chat box. Is it clear? Next. Which orthodontic surgery procedure is considered the most unstable? Now there is a particular hierarchy of stability of orthodontic surgical procedures which has been enumerated by Prophet. This table has been taken from textbook of Contemporary Orthodontics by William R. Prophet. According to him, this is the sequence of stability of orthodontic surgical procedures. So, in the middle we have stable predictable procedures. Whenever you move the maxilla up, or you move the mandible forward, maxilla forward, or mandibular back, and asymmetrical correction of the mandible. So these are stable. Only condition is that you have to go for rigid fixation only. And you go up, that means for more stability, example could be you can move the maxilla forward, or you can correct the asymmetry of the maxilla. And very, very stable is you move the maxilla up. Example, Leafwood 1 surgery, whenever you want to treat the vertical maxillary axis, or you move the mandible forward, or you move the chin in any direction. These procedures are very stable. But on the other hand, if you move the mandible back, or you move the maxilla down, or you move them, or you expand the maxilla transversely, so these are problematic, and the prognosis of stability of these procedures for a long term is questionable. Okay, that's why widening the maxilla falls under the most problematic situation, which is the least stable out of all procedures. Okay, that's why option A will be the correct answer. You have to remember this table by heart. Very many times I've seen questions out of this particular table. You have to remember this table. Okay, students, you have to remember this table. This is important. Next, again a conceptual question and a confusing one as well. The counteracting torque for bodily translation of following tooth will be. Now question is asking counteracting torque for bodily tooth movement, for bodily translation. It's a numerical question and conceptual question are both at the same time. Now, you know the concept of moment. What is moment? It's the tendency to rotate a tooth whenever the force is applied at a certain distance from the center of resistance of the tooth, right? So this red dot is the C res of the tooth, but the force applied is here at the bracket slot, which is at say 10 millimeter distance from the C res. Now moment is force into perpendicular distance. It's a vector quantity. That means 120 gram into 10 millimeters is equal to 1200 gram millimeter. It's called moment. But as I said, it's a vector quantity. It has to have direction also. Right? We know the magnitude. Now what should be the direction? Now whenever you move the tooth, whenever you want the tooth to move in a tipping manner, so this is the direction of moment, clockwise. This should be the direction of moment, clockwise. Now the question is asking counteracting torque. That's where the principle of counterbalancing moment comes into picture. Counterbalancing moment. You can also say MC to MF ratio. It's one and the same thing. Both can be used interchangeably. Now what happens? What is the concept of counterbalancing moment first of all? Now, in most of the clinical situations, you use a fixed appliance, fixed orthodontic appliance. Very rarely and very seldomly nowadays we use removable appliances. other than aligners. Aligners is a separate topic altogether. We are not talking about aligners. We are talking about simple removable orthodontic appliances like Holly's appliance. For active tooth movement, we don't do that. We don't use it anymore. Very, very rarely it happens. Okay. Now you know the type of tooth movement achieved by simple removable appliances is simple tipping. In case of tipping, there is no counterbalancing movement because there is no bodily tooth movement. But whenever you are using fixed orthodontic appliances, the forces are generated here at the bracket slot in this area, which is at some distance from the serous of the tooth, as I just exemplified in this question. To allow bodily tooth movement, please listen to me carefully again. To let the tooth move bodily, this moment 1200 gram millimeter, the direction, that is clockwise direction, has to be counteracted by yet another type of moment. That is called counterbalancing moment. Did you get what I said? The moment generated at the bracket slot to counteract the tipping moment is called counterbalancing moment. Simple as that. Okay. So counterbalancing moment for bodily tooth movement should be 1:1. So if the moment of force is 1200 gram millimeter clockwise, the counterbalancing moment should be 1200 gram millimeter in an anti-clockwise direction. So what should be the answer? Answer should be option D, that is 1200 gram millimeter anti-clockwise. I have seen one more question very similar to this, but the gray tooth, it has been moved like this. So what type of tooth movement is this? It's tipping tooth movement. It's control tipping, simple control tipping. Now for control tipping, MC to MF ratio should be less than 1. It should be less than 1, right? So in that case, the counterbalancing moment should be less than 1200 gram millimeter, but that can also be in an anti-clockwise direction. In that case, option B would have been the correct answer. Is it clear? So these are the ratios. This is a simple moment to force ratio. You have to remember these. For uncontrolled tipping, the moment to force ratio is 0:1. For controlled tipping, this is for uncontrolled tipping. For controlled tipping, it is 6:1. For translation, bodily movement of the tooth, it should be 10:1. And for torque or root uprighting, it should be more than 10:1. That is simple moment to force ratio. This is the same, and we have different values of tooth movements in gram. You have to remember these values and these values also. You have to learn them by heart. It is important for you to learn them by heart. Okay? Now this is what I was talking about. It's called moment of couple to moment of force ratio, or also known as counterbalancing moment. Now for an uncontrolled tipping, the moment MC to MF ratio should be 0. That is simple pure tipping. Now whenever MC to MF ratio is more than 0 but less than 1, we see control tipping. Whenever the ratio is 1:1, we see bodily movement, as I just showed in the question above. And when it is more than 1, you get root torquing. So the clinical importance of MC to MF ratio is basically this blue box. This ratio gives an idea of the type of tooth movement expected in a clinical setting. This is another MCQ for you guys. I've seen an MCQ somewhere that what is the clinical implication of studying MC to MF ratio? What is the clinical implication? This is the clinical implication, that this ratio, by studying this ratio, you can have an idea of what type of tooth movement you are going to expect in the clinical scenario. Okay, I hope this is clear. All right, an IBQ, and many people have a confusion in this in this IBQ. What is the appliance shown in the image? Is it a hybrid pendulum? Is it a hybrid T-Rex, frog appliance, or is it a first class appliance? What do you think it is? It is hybrid T-Rex appliance. Let's take a look at each one of them. So this is a Pendex. It's a modification of pendulum appliance. You have a jack screw in the acrylic portion, so that has a provision of transversely expanding the maxilla. At the same time, you can distalize the molars as well. So that is a modification given by Hilgers. That's why it's called pendulum plus expansion equals to Pendex appliance. Sorry. Next is M pendulum. M pendulum, only a very subtle change, a very subtle minor change is that the direction of U loop of the TMA springs is reversed. Excuse me, I'm having cough actually today. Excuse me about it. Then third is Hilger's PhD appliance. You can see there is no acrylic component, and we have hybrid T-Rex appliance, as this question was asked in the image-based question. So this consists of TADs. It consists of palatal TADs. Okay, that is hybrid T-Rex appliance. So what is a frog appliance? It's a molar distalization appliance from a company called Foresta Dent, which is based in Germany. It is designed with acrylic plate or fixed palatal screws for molar distalization without tipping of the molars. So this is what a frog appliance looks like in the clinical picture, in the clinical scenario. And why is it called a frog appliance? Because the design of that appliance is somewhat, if we extrapolate it, if you imagine it, you can see the design. Similarly, it mimics a frog ready to take a leap, ready to hop. That's why it's called a frog appliance. It's not an acronym for anything. It just mimics a frog ready to take a jump. That's why it's called a frog appliance. And the fourth option asked in the question was first class appliance, which was developed by Dr. Arturo Fortini, Dr. Massimo Lupoli, and Dr. Massimiliano Pari. These are Italian researchers, and this is what it looks like. It's an intraoral molar distalization appliance. That is first class appliance. Okay. Next question. Which of the following statements is false in relation to bird face deformity? Now, what is bird face deformity? Bird face deformity is a serious problem in the temporomandibular joint area that could have been the result of TMJ ankylosis. Now, because of long-standing TMJ ankylosis, what happens? The patient has not been able to open the mouth, has not been able to do functional movements of the mandible, right? So this is how the patient looks like clinically. The upper jaw grows normally, but the lower jaw doesn't grow. It is severely retarded. It is severely retrognathic. So it gives an appearance that the patient the patient is constantly opening the mouth, and upon looking from the side, the profile view of the patient gives an appearance of a bird face, having a beak and a goblet-like chin thickening, that double chin appearance, That's why it's called bird face deformity. Now, once you shoot a latticephalogram, this is how the tracing of a bird face deformity patient looks like, as you can see in the picture. Okay. Now, the posterior facial height is measured from cella to the gonion, and the anterior facial height is measured from nasion to mentor. Right. Now the anterior facial height is increased. Why? Because the patient is severely hyperdivergent. The patient is severely vertically growing. The patient is severely vertically growing. Okay, that's called hyperdivergent facial profile. Right? But the thing you have to see here, okay, let me first look at the options. Which of the following statements is false? Class 2 malocclusion, I just said the patient has severe retrognathism, retrogenia, retrognathia, more FMPA. FMPA means Frankfurt mandibular plane angle. Yes, that is also true. And more posterior facial height. This is not true. It is false. Now this parameter sella to gonion is very small. Whereas the anterior facial height from nasion to menton is large. Now you calculate the Jara-Back ratio. There's a particular parameter called Jara-Back ratio. How is it measured? It is measured posterior facial height upon anterior facial height into 100. It is expressed as percentage value. Now, if you increase the posterior facial height, if this is the normal value, before that the normal value is 62 to 65% in normal case scenario. Anything more than 65% contributes to vertical growth pattern, and it contributes to horizontal growth pattern, and anything less than 62% contributes to vertical growth pattern. For vertical growth pattern, the posterior facial height should be small and anterior facial height should be normal or more than normal. In that case only you're going to get the percentage value less than 62%. Now in this case, the posterior facial height is reduced and anterior facial height is increased. So what exactly you're going to get here? You're going to get a value which is much less than 62%, indicating a vertical growth pattern, severely vertical growth pattern. Okay, so the parameter which is false is more posterior facial height, right? Now next question, guys, are you with me? Please let me know in the chat box. I cannot see any activity since long. Just type yes or no if you are with me. Please let me know in the chat box. Next question. Which of these appliances can be used for non-surgical treatment in this patient, which shows definitive pre-surgical improvement? Now there's a hint. There's a hidden hint within the language of the question. It is saying which shows definitive pre-surgical improvement. Oral screen, nasoalveolar molding appliance, obturator, or Frankel appliance. So there should not be any doubt. The correct answer is nasoalveolar molding appliance. NAM, nasoalveolar molding. Now, what is the goal of nasoalveolar molding? Basically, we give an appliance to the infant. We take a impression of the implant using tear-resistant alginate. If I'm not wrong, the surgeon has to take an impression. It has to be sent to the lab to make this particular appliance for the patient. So this is a NAM appliance, as you can see in the figure. And on the right side, this is an obturator. So this is yet another image-based question, yet another MCQ which can be asked, that which appliance is which. So you should be able to identify them. Now coming back to the question, what are the goals of NAM? So basically an appliance which has to be fabricated, which can be given to the patient, which can be given to the infant, is a NAM. So basically what we are doing, you are going to redirect, you are going to mold the soft tissues of the mouth, soft tissues of the face in such a way so that the proximity of soft tissues is, I mean to say, the soft tissues come in close proximity to each other. That helps in the growth of the stomatognathing complex. So even before the first surgical incision is made by the cleft surgeon, the tissues should be in so much approximation to each other that not much effort and not much expertise and not much post treatment morbidity could be observed by the patient. That is the objective. Let's take a look. To restore the correct skeletal, cartilaginous and soft tissue relationship pre-surgically, to align and approximate the intraoral alveolar segments, to correct the malposition nasal cartilages, to correct the nasal tip and alar base on the affected sides as well as position of the philtrum and columella. The NAM device reduces the number of surgeries required during a patient's lifetime, which in turn reduces facial scarring, trauma, inconvenience, and cost involved in additional surgeries. And last but not the least, pre-surgical molding means that things are where they should be or as close as possible before the surgeon even makes the first incision. As I just said, so this appliance helps in molding of the soft tissues. Molding of the soft tissues. And this molding of the soft tissues, it made possible only because of presence of ground substance called hyaluronic acid. This is important. You have one more MCQ. So the molding of the soft tissues is possible only because of excessive quantity of hyaluronic acid present within the infant's tissues. Okay? So correct answer will be option B. That is, how do you take mold of the infant's appliance? Infant's mouth. I told you the surgeon has to make the impression using tear-resistant alginate, creating a custom-made plastic plate of the child's mouth and of lip and nostrils. Step 3. The child will wear the plate 24 hours a day for approximately 6 months. Adhere the plate with the child's mouth using surgical tape. And step 4. Each week, the orthodontist will reshape the plate, reducing the child's cleft for reshaping the facial features. So this is how it goes. This is how the follow-up appointments are there. Next. Treatment for a patient with skeletal class 2. Open bite and long face should be done with. So we are presented with 3 conditions. Class 2 malocclusion, open bite, we don't know whether it is skeletal or dental, and long face. So long face, most probably the open bite could be skeletal. Okay. High pull headgear, functional appliance plus high pull headgear, functional appliance only and no treatment alone. Now you have to give a functional appliance because the patient has skeletal class 2. Right? Open bite and long face can be corrected by giving a high pull headgear. So a combination of functional appliance plus high pull headgear is required to correct this particular condition. Okay. High pull headgear, why? Because one of the effects of high pull headgear is that it causes intrusion of the upper molar. The line of forces are such that one of the effects of high pull headgear is intrusion of the upper molar. Now, intrusion in this case is beneficial for us. Why? Because the patient has an open bite and also a long face. Now, once the uppers are intruded, the long face syndrome will get corrected because the mandible will get auto-corrected, auto-rotated in an anti-clockwise direction. So that is beneficial for us in this particular scenario. That's why we'll choose option B, that is functional appliance plus high pull headgear. Now this is a question a lot of students have query with. Frankel regulator is best used in which period? Early mixed dentition, late mixed dentition, permanent dentition or deciduous dentition? Research says, maximum number of research articles says that function regulator is best used in early mixed dentition period. Rest all the functional appliances should be used in late mixed dentition period. Please mind my words, you have to remember this. Frankel appliance is the only exception. It's the only myofunctional appliance which has to be used in early mixed dentition phase. What are different types of function regulators? We have FR1A, FR1B, FR1C, FR2, FR3, FR4, and FR5. So many different types of FRs are there. And it has to be used in early mixed dentition period around 7 to 9 years of age. It is called an oral gymnastic appliance. Why gymnastic appliance? It is not going to dance in the mouth, right? Gymnastic means this appliance will mold the oral cavity in such a way, and specifically the tongue and all the structures associated with the tongue. If it is able to modulate the tongue properly, so the other structures can grow properly. Other structures will follow the contour of the tongue, basically. So earlier the better. The younger the child is, the better it will be for the child to adapt this particular appliance, to make it a habit to wear that appliance on a constant basis, on a consistent basis. Okay, so that's why early mixed dentition, it is used in early mixed dentition as compared to other types of functional appliances. Again, a conceptual question. Example of one couple system is, all right, let's first understand what is one couple versus two couple system. Let me draw a diagram for you. This is lateral, central, central, and lateral. We have the brackets bonded here, right? And we have a utility arch coming from the molar tube on both sides. Now in one couple system, what happens? We have a green section of wire attached from lateral incisor to lateral incisor, making it a single unit. You can see in the diagram here that green colored arch wire is called a sectional arch wire. It's called sectional arch wire. It is inserted from the lateral incisor to lateral incisor, and you are going to ligate the intrusion arch to the sectional arch wire using a single point contact. So this yellow color is the ligature type. So that means the utility arch is attaching itself to the sectional arch wire at a single point, right? So because of this configuration, the orthodontist is in a position to exactly know what is the magnitude of force and what is the direction of force, direction of moment, what is the direction of net moment. So these two parameters can be known for sure with acute precision in case of a one couple system. That is why it is synonymously called as statically determinate system. Determinate system as in we can know exactly what is the amount of force and what is the direction of net moment acting on that system. Okay. Example, an intrusion arch made from rectangular wire which fits into a rectangular tube on the molars and is tied to one point of contact on the incisor segment is an example of determinate one couple system. One more example is a cantilever spring. One more example is cantilever spring. More specifically used to bring down an impacted tooth or labily placed canine, as in this particular example. A cantilever spring made from rectangular wire that fits into a rectangular tube or bracket on one end and is tied to one point of contact on the other produces a determinate one couple system in which the force and moments can be known precisely. That's exactly what I said. Now, how is it different from two couple system? I'll draw the diagram again. These are the square are the brackets bonded to the teeth. We have the same utility arch coming from the molars. Right? Now you see the fundamental difference between one couple and two couple system is that in two couple system, we don't use a sectional arch wire. A sectional arch wire is not used. What we use instead, the same utility arch, the anterior section of the utility arch goes inside the bracket slot of the lateral incisor to lateral incisor as a single unit. So we are not tying this utility arch with the ligature tie separately. So it is contacting the brackets at multiple points. It is contacting the brackets at multiple points. Right? Because of multiple contacts, it is not possible for the orthodontist to determine the exact magnitude of forces. Neither it is possible for the orthodontist to determine exact direction of net moment. So we cannot determine exactly what is the force and what is the direction of movement in a very precise manner. That is why a two-couple system is also known as statically indeterminate system. Indeterminate system, we are not in a position to determine. That's why it's called indeterminate system. So utility arch often is an intrusion arch in two-couple configuration created by tying the rectangular intrusion arch into the brackets on the incisor. When this is done, the precise magnitude of forces and couples cannot be known. This is what I was stressing upon. Now let's look at the options. Example of one couple system is a rectangular intrusion utility arch not engaged in the slot having a single point contact with anterior with a rectangular wire sliding in the rectangular tube in the posterior. Right? So this is what is one couple system is. I showed you with the help of a diagram earlier. So rectangular utility arch which is not engaged in the bracket slot, but it has a single point contact with the ligature tie. I told you we have to tie the utility arch with the ligature tie, creating a single point contact with the rectangular wire sliding in the rectangular tube in the posterior. The rectangular wire is free to slide in the rectangular tube, in the molar tubes. So that is an example of one couple force system. Okay? Next. Which property of an orthodontic arch wire is demonstrated by its ability to be bent completely around the thumb without breaking? Flexibility, stiffness, resilience, or formability? What should be the answer? Please tell me what should be the answer. Guys, I cannot see any new comments on the chat box. If you are with me, I want you to type at least a yes or a no so that I can know exactly how many people are actively listening to my lecture. Please let me know in the chat box how many of you are actively listening to my lecture. So which property? It is formability. It is formability. What is formability? It's a capability of a material to undergo plastic deformation to a given shape without being damaged, and the metal is able to undergo a large amount of strain or work hardening. That is the definition of formability. Resilience is a relative amount of elastic energy per unit volume released on unloading of the test specimen. So if you draw a stress strain curve, up to proportional limit, the area within the graph is known as resilience. Beyond the proportional limit to the ultimate fracture point, the area within the graph is known as formability. And the entire area, that is resilience plus strain plus formability, is known as toughness. The sum total of resilience and formability is known as toughness. Okay? Right? So correct answer will be formability. Next question. While treating increased anterior overbite while keeping the mandibular plane same, again a conceptual question, I want you to pay attention. Increase in the molar height is compensated by absolute intrusion, relative extrusion, or absolute extrusion. All right, before answering, let's take a look. What are the three different possible ways to level out a lower arch with an excessive curve of speed? One method is absolute intrusion of the anteriors. You can see here, you can make the mechanics in such a way that causes absolute intrusion of the lower anteriors. The incisors themselves are intruding. That is absolute intrusion. Okay. Next is relative intrusion. Now what happens here? It is achieved by preventing the eruption of incisors by vertical ramal growth provides vertical space into which the posterior teeth erupt. Now the meaning of relative intrusion is quite complicated. I'll explain you. So basically what is happening, you have created certain mechanics in which the molar itself is erupting, but it is not erupting. Did you get my point? The molar is erupting, but it is not erupting. What is happening here? The ramus is growing in a vertical dimension. So this is what we are going to achieve during the growth phase of the child, of the teenager. So the ramus is growing in a vertical dimension. You can see here, this orange colored graphical representation is the excessive growth of the mandible, which has occurred in the vertical plane. And the exact amount of eruption of the molar is exactly the same as the vertical growth of ramus has taken place. So this molar is erupting by exactly the same amount by which the vertical growth of the ramus has occurred. So that is known as relative intrusion. It's not extrusion, it's relative intrusion. And third one is extrusion, simple extrusion. That is elongation of posterior teeth, which causes the mandible to rotate downward in the absence of growth. Mark my word, this is absence of growth. But this is happening during the growth. Okay, just you have to mention this. So what is happening in the extrusion part? We are actively making the molar erupt. We are actively doing some mechanics which facilitate the eruption of the molar. Upon doing so, because of the wedging effect, what happens? The mandible rotates in a downward and backward direction, thereby increasing the mandibular plane angle in relation to the Frankfurt horizontal plane, if you look at it in a lateral cephalograph. Note that the difference between 2 and 3 is whether the mandible rotates downward and backward, which is determined by whether the mandibular ramus grows longer while the tooth movement is occurring. Now, if you are given a question which says specifically that the mandible has grown in a downward and backward direction, or the mandibular plane has increased, in that case, what would have been the answer? In that case, the answer would have been absolute extrusion. But in this question, it is saying while keeping the mandibular plane angle same. By keeping the mandibular plane angle same in the scenario of relative intrusion. In the scenario of relative intrusion. Okay? Next question. Prolonged use of Milwaukee brace will cause. Now, what is Milwaukee brace? Now, this was an orthopedic appliance developed in the University of Wisconsin. University of Milwaukee. There's a, I don't remember the name of the state of the USA in which the place called Milwaukee is located. I don't remember that. I'm sorry. So it was developed in the University of Milwaukee. That's why this orthopedic appliance is known as Milwaukee brace. This is how it was. Why I'm saying it was because it is obsolete now. It is not used anymore. Over the time, the researchers have found quite a lot of adverse side effects because of prolonged use of Milwaukee brace. What exactly it used to do? It's an orthopedic appliance basically used to correct the scoliosis, kyphosis, and lordosis of the spine. Basically, to correct the curvature posture of the patient, the orthopedicians made the patients to wear this particular appliance. But unfortunately, it has an occipital ring which takes the support from the mandible. It is fixed to the mandible in such a way, mandible and the neck also, in such a way that the adverse effect which was found after many studies after a certain period of time was that it used to cause retardation of growth of the mandible. So whenever you take anchorage from a structure for a long period of time, that structure is not going to grow properly. That is what happened with the mandible. Upon prolonged use of this particular appliance, the mandible was found to be growing in an insufficient way. So, when the mandible is not able to grow properly, class 2 will be the result. Severe class 2 will be the result because of mandibular retrognathism. That's why it is banned now. It is obsolete. We have different type. We have much better different types of appliances available nowadays instead of Milwaukee brace. Now this is an interesting question. A question which requires presence of mind. A question which requires understanding of the core concepts of growth and development of the mandible. Okay. A needle fragment embedded in the anterior border of ramus of mandible of a 6-year-old child would soon become embedded more deeply as new bone covers it, soon become free in the soft tissues as resorption uncovers it, remains on the surface as the ramus was translated, and it simulates formation of bony protuberance at the site of tooth fragment. Now let's take a look what is happening here. If you know the concepts of the growth of the mandible, you must be aware of this particular diagram. So the yellow colored mandible is that of a child, is that of an infant. The orange colored mandible is that of a young child, and the green colored mandible is that of an adult. Okay. Now you will see how the mandible is growing. It is growing in a posterior superior direction. If you take the chin as a constant point of reference. Okay. Now we have discussed about it earlier that the anterior border of the ramus of the mandible undergoes severe resorption, whereas the posterior border of the ramus of the mandible undergoes severe bone deposition with time. As the person ages, as the child matures towards teenage and young adult and finally an adult. Now you know the question is asking that a needle fragment embedded in the anterior border of the ramus of the mandible of a 6-year-old child. Now the needle, what the researchers have incorporated was here, that red dot along the anterior border of the ramus of the mandible, right? What will happen later to that needle? Now you know the direction of growth of the mandible I just explained. So the anterior border of the ramus is completely resorbed and the posterior border of the ramus is formed. It's formed by new bone formation, new bone deposition. So what you are going to observe here, it would soon become free in the soft tissues as resorption uncovers it. So that's why I said this question requires logic, presence of mind, and understanding of the core concepts of development of the maxilla and the mandible, postnatal development of the maxilla and mandible particularly. We have covered this in the live and recorded lectures and also in the notes, right? So I hope you must be aware of all the concepts behind the growth and development, and I hope you would be able to answer this question maybe in just 30 seconds of your time. Okay. Next question. All of the following are secondary messengers in tooth movement except Secondary messengers. Now, secondary messengers are a concept of pressure tension theory. Pressure tension theory of biology of tooth movement. Right? Calcium ions, cyclic adenosine monophosphate, cyclic guanosine monophosphate, or prostaglandins. Now let's take a look about the sequence of events, what is happening. Sorry. So whenever an orthodontic force is applied to the tooth, what is the first result? Because of the prolonged forces, physiological forces, there is some amount of tissue trauma. And whenever any tissue undergoes trauma, what is the first thing which is happening? Inflammation. Inflammation is caused because of cytokines. And one of the cytokines is prostaglandins. Particularly PGE2, prostaglandin E2. That is the most common prostaglandin involved in inflammation reactions. This prostaglandin is called first messenger. Right. This prostaglandin is called first messenger. Now it reaches the cell membrane. It reaches the cell membrane, but because the prostaglandin is very large in size, the molecule size of prostaglandin is quite large. So it cannot directly penetrate inside the cell. To allow that, for the information from the extracellular matrix to go inside the cytoplasm, the prostaglandins attach themselves to integrin molecules, which is present on the cell membrane in a transmembrane fashion, transmembrane protein fashion. You know that that model called fluid mosaic model of plasma membrane? That's exactly what I'm talking about. Now that information from outside the cell has to be transmitted to inside of the cell. This happens by two pathways. Synthesis of cyclic adenosine monophosphate or cyclic guanosine monophosphate, either of that. Then liberation of secondary messengers and activation of calcium. What happens then? Protein kinase enzyme within the cell, they further activate the protein kinase enzyme within the cell, which are called tertiary messengers. And that gets inside the nuclear membrane to cause phosphorylation changes within the chromatin network of the chromosomes. That chromatin undergoes DNA replication, followed by mRNA synthesis, that is transcription, and finally out of transcription certain proteins are manufactured, proteins are synthesized by a process called translation. And this translation leads to formation of certain bone remodeling proteins like collagen, like calcium phosphate, all other different types of proteins are there. Bone morphogenetic proteins, BMPs they are called, bone morphogenetic proteins. So ultimate end result is remodeling of the bone. And this remodeling of the bone is what is responsible for moving the tooth from one place to another within the oral cavity. So this is the summary of pressure tension theory. Now, which of the following are secondary messengers? Calcium ions are secondary messengers. CAMP is a secondary messenger. CGMP is a secondary messenger. Which is not? It is prostaglandin, that is primary messenger. It is present outside the cell within the extracellular matrix. Rest all the secondary and tertiary messengers are present within the cell intracellularly. Okay. Next, genoplasty refers to insertion of a plastic material within the soft tissues of the chin to increase its size. Is a genoplasty? I don't think so. Surgical procedure which alters the shape, size, or position of the chin in all three dimensions of space. Gene therapy to reduce the tendency to develop a malocclusion. You know, these examiners are quite clever. They want you to get confused, deliberately. They want to confuse you. So, genoplasty It is synonymous to gene therapy. That's why they've included gene therapy within the options. It is your responsibility as a student that you should not get confused by these misleading options from the examiner's side. And option D, gene therapy to induce the formation of a prominent chin button contour. So what is the answer? None other than option B. It's an adjunctive surgical procedure which alters the shape, size or position of the chin in all three dimensions of space. So basically, genoplasty is an adjunctive surgical procedure which can be classified as a cosmetic procedure. We can cosmetically uplift or alter the shape of the chin. Even after correction of the malocclusion, some patients are aesthetically highly sensitive. They want exactly celebrity-like appearance of the face. There are patients, you can't help them. You can't actually, they have got way too high, unrealistic expectations. But it's not possible to fulfill all expectations of everyone, right? So we have certain adjunctive surgical procedures which can alter the shape of the chin, which can augment the chin by a procedure called augmentation genoplasty, which can reduce the prominence of the chin by reduction genoplasty. Then we have a straightening genoplasty and we have a lengthening genoplasty. There are different sub-classification of these main classification as well. So I'm not going into much detail right now. So all you should know is that genoplasty is an adjunctive surgical procedure to improve the cosmetic quotient of the face of a patient. Okay. So this diagram explains everything. We make a osteotomy cut of the chin, and based on the requirement of the patient, based on the requirement of the case, we can move the chin in any direction as it is shown by different arrows in different directions. So that is about genoplasty. So option B is correct answer here. All right. So I think that is all for you guys. These were the 15 most important previous year questions which I have come across, which I want you to make a note. This is the answer key for all of you. If you have any discrepancy, if you have got any doubt, you can very well come back to that particular question, tally it with this answer key, and then you can go about answering the questions. Okay. With that note, you know where to find me if you have any doubts. You have a WhatsApp group, Orthodontic Doubt Solving group. You can tag me there. You can tag me on Telegram as well, in the group which is particularly dedicated for different batches of students, and I'll be very happy to help you. With that note, do I have any questions? No, I don't think I have any questions as of now. I think everybody of you are busy in preparations of Diwali. That's why I think none of you was active today in the session, and I think all of you are going to uh, watch this session later on. That's what I can presume from the activity of the students. Anyways, that's totally fine. I understand it's a season of lights, it's the festival of lights. So I don't want you to disturb. So all the very best. Study well, work well, work out well, eat well, and most importantly, wish you a very, very happy Diwali and Dhanteras. Take care, guys. All the best.